My dear colleagues, friends, ladies and gentlemen, first of all, I would like to wish you a very, very happy New Year 2023. And today we are here to start the first webinar of the year. Coming to today's webinar, we have 4 panelists come moderators. That includes me. And we have 5 speakers who are all eminent in their own fields of practice of field of practice of anesthesiology. And I request Dr. Akkamahadevi to take the podium and conduct the meeting.
Good evening, sir. It is indeed an honor to be a part of this esteemed webinar. And coming to the subject as such, as per the systematic review and meta-analysis by Daniel et al. Regarding the prevalence of COPD in India, it is 7.4%. And it's the 4th leading cause of death. And so many times these patients come to we anesthesiologists either in the operation room or in the critical care area. And patients with COPD are at increased risk of developing perioperative complications and mortality. We know all about it very well. So it's very important that we as anesthesiologists, we understand the basics, we assess the patients properly and risk stratify, optimize them and decide on whether regional anesthesia is to be given or general anesthesia is to be given to the patients, and handle the acute exacerbations in the perioperative period and manage the patients in critical care area. So to cover all these things, we have esteemed doyens in anesthesiology who are experts in this subject to enlighten all of us in these topics. And I would end by saying, the plight of an anesthesiologist who faces bronchospasm or acute exacerbation of COPD can be compared to a person who is suffering labor pain. It can be only experienced and it cannot be explained. So with that note, I would like to introduce Dr. Prasad to take over as first lecture on basic. Yeah, Dr. Prasad, happy to see him as one of the faculty. He is the professor and head the Department of Anesthesiology, ESI Medical College, Rajajinagar, Bangalore. His achievements are he has several publications in national and international journals with special interest in obstetric anesthesia, pediatric anesthesia, anesthesia workstation, and physics and anatomy. Over to you, Dr. Prasad.
Thank you, madam. Thank you for a kind introduction. It's a pleasure. At the outset, I bring warm greetings from ESI Medical College, Bangalore. Happy New Year to everybody. And today, my topic is the pathophysiology of COPD. So, regarding pathophysiology, as we all know, pathophysiology is very important for the anesthesiologist because pathophysiology means because of the pathology, what are the physiological changes that takes place in the body? We as anesthesiologists are very good at managing physiology. For example, if there is hypoxia, we correct hypoxia. If there is hypotension, we correct hypotension. So we are very good at managing physiology. So that is the reason why we have to know pathophysiology, and pathology most of the times it is managed by the physicians, but we have to have a knowledge about the pathophysiology. In this regard, knowing pathophysiology of any disease is very important for the anesthesiologist. Today, I'll be discussing about the pathophysiology of COPD. Coming to chronic COPD or chronic obstructive pulmonary disease, COPD is an umbrella term used for several chronic inflammatory diseases, primarily caused by long-term inhalation of harmful particles. This mainly affects the airways, the lung parenchyma, and the pulmonary vasculature. And the characteristic features are persistent respiratory symptoms like cough with expectoration, breathlessness, and the most important is airflow limitation. Patient may have symptoms. If it doesn't have airflow limitation, it is not considered as COPD. And this airflow limitation is not fully reversible, and it is usually progressive. And if the chronic inflammatory process affects mainly the airways, it is called as chronic bronchitis. if the inflammatory process affects the parenchyma, it's called emphysema. But in a given patient, there is both chronic bronchitis and emphysema together most of the times. Coming to the definition of COPD, according to the National Heart, Lung and Blood Institute and WHO, COPD is a chronic respiratory disorders that leads to progressive tissue degeneration and obstruction in the airways that is not fully reversible. This is very important. Reversible, you can see in asthma, but here in COPD, it is not fully reversible. There are debilitating conditions that affect the individual's work and function independently. The conditions which comes under the purview of COPD are chronic bronchitis, asthmatic bronchitis, emphysema. Asthmatic bronchitis, it's a chronic condition, but here the airflow obstruction is reversible. Now, according to American Heart Society, according to the American Thoracic Society, COPD is a disorder characterized by abnormal test of expiratory flow. This abnormal test expiratory flow usually we find out by using spirometry, and that do not change markedly over a period of several months of obstruction. What are the risk factors for COPD? The risk factors are usually cigarette smoking, occupational exposure to dust and chemicals, especially people working in gold mines, textile industries, etc. Indoor and outdoor pollution nowadays, recurrent childhood respiratory infections, and even low birth rate in pediatric patients are causes for COPD. Coming to pathogenesis, what leads to the pathology? Because when the patients are exposed to, for example, smoking, this smoking leads to lung inflammation. The amount of lung inflammation depends upon the host factors and the amplifying mechanisms. Based on the imbalance between the oxidants and the antioxidants, it leads to COPD. But when there is a lung inflammation, there is increased oxidative stress on the patient and leads to COPD. And the other mechanism proposed is imbalance between the protease and the antiprotease, which leads to increased protease activity, which damages the elastic tissues and cause COPD. Coming to the definition of chronic bronchitis, usually chronic bronchitis is defined as patient who has got cough with expectoration for at least 3 months in a year for 2 consecutive years. COPD, chronic bronchitis is clinically defined. It is not based on any investigation. It is diagnosed based on clinical conditions. It is a clinical condition defined where there is excess mucus secretions in the tracheobronchial tree and which is caused by, which leads to edema and bronchial inflammation. And sputum is thick and it obstructs the airflow. Coming to emphysema, emphysema is diagnosed, by definition, it is anatomical defined condition which is characterized by abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without any obvious fibrosis. There is a lack of uniformity in airspace enlargement, resulting in loss of alveolar surface area. Now, coming to the differentiating characteristic features between chronic bronchitis and emphysema. Chronic bronchitis, usually patients are overweight. They are considered as blue blotters because cyanosis is very prominent in chronic bronchitis. Whereas in emphysema, usually the patients are normal built and they usually breathe through pursued lips, and the cyanosis is not very obvious, and they are usually considered as pink puffers. And coming to the breathlessness, in chronic bronchitis, it is mild breathlessness, whereas in emphysema, the breathlessness is severe. In chronic bronchitis, there is copious secretion of sputum. In emphysema, it is scanty. And infections are very common in chronic bronchitis when compared to emphysema. Hypoxemia is common in chronic bronchitis, and it is less in emphysema. And the diaphragm is normal shaped in chronic bronchitis, whereas in emphysema, because of hyperinflation, the diaphragm is flattened and the chest is barrel shaped. And cor pulmonale is very common in chronic bronchitis, and diffusion capacity is decreased in emphysema. Coming to pathophysiology, pathophysiology involves interaction of genetic and environmental factors that lead to inflammation and damage to airways and alveoli. Airway becomes narrow and blocked by inflammation and scarring. Alveoli becomes damaged and scarred, reducing the ability to exchange gases. Coming to the pathophysiology, because of the smoking and other occupational exposure, this leads to increased oxidative stress, and which leads to inflammatory, which releases the inflammatory mediators, These inflammatory mediators results in increased globular cells and submucous gland enlargement, which leads to mucus hypersecretion and ciliary dysfunction. At the same time, these inflammatory mediators also results in long-term lead to fibrosis and thickening of the bronchial walls, which leads to narrowing of the airways. This results in the fixed narrowing of the airways. That is why the process is not reversible, which leads on to airway obstruction, which leads to chronic bronchitis. At the same time, these inflammatory mediators and leads to damage to the alveoli, which includes the terminal respiratory bronchiole, the alveolar sacs, and the duct, which results in destruction of the alveolar wall and capillaries. And because of the destruction of the alveolar wall and capillaries, it leads to decrease in the elastic recoil property and results in enlarged air spaces, which in turn leads to hyperinflation. At the same time, the destruction caused by inflammation also causes loss of alveolar attachments, decreasing, causing air trapping and on expiration and hyperinflation, which leads to emphysema. Coming to the molecular mechanism, the mechanism here is the presence of perpetual inflammation because of the imbalance between the oxidant and antioxidants. The inflammatory mediator cells are released like neutrophil, macrophages, and lymphocytes. This in turn leads will releases the mediators like cytokines, and cytoattractants, which cause damage to the tissue. Neutrophils basically causes the damage to elastic lung tissues through chemoattractants and proteolytic enzymes. The chemoattractants are interleukin 8 and leukotriene B4. The proteolytic enzymes are elastase 4, proteinase 3, cathepsin G, and cathepsin B. And the macrophages also causes damage by releasing cytokines, and it also releases elastolytic cysteine proteinases, which causes damage to the elastic tissue in the lungs. Coming to lymphocytes, these lymphocytes induces apoptosis of the alveolar epithelial cells, and at the same time, it also causes autoimmune response to the lung tissues. Both this results in release of destructive enzymes and causing damage, and also it leads to autoimmune responses. So, in the end, the pathological changes are oxidative inactivation of antiproteases, damage to the surfactants, mucus hypersecretion, membrane lipid peroxidation, alveolar epithelial injury, remodeling of the extracellular matrix, reduction in elastin collagen synthesis, fragmentation of the skeletal muscle protein, and steroid unresponsiveness. In short, the pathophysiologic changes because of the pathology, the physiologic changes are it causes air trapping, fixed airway narrowing, and increased airway resistance and ventilation perfusion mismatch. We'll try to understand how this takes place, each one. Coming to air trapping, because of the elastin proteolysis, results in decreased elastic recoil pressures. This results in airway narrowing, which causes air trapping and airflow obstruction in the bronchioles. Coming to the fixed airway narrowing, the fibrotic remodeling of the airways result in fixed airway narrowing, which results in increased airway resistance. Coming to the ventilation perfusion mismatch, the apoptosis of the alveolar, bronchial, epithelial cells and pulmonary capillaries, and also emphysematic changes, decreased surface area for gas exchange results in ventilation perfusion mismatch. So the cardinal features of COPD are fixed airway obstruction, alveolar hyperinflation, pulmonary hypertension, and changes in the respiratory drive. Coming to the fixed airway obstruction, because of the fixed airway obstruction, there is outflow obstruction. So all the flow parameters, when you do a spirometry, the FEC, FEV1, and FEC and FEV1 per FEC ratio, and PEFR, peak expiratory flow rate, and FEF 25 to 75%, that is forced expiratory flow in 25 to 75% is reduced, and also maximum voluntary ventilation is reduced. So all the flow parameters are decreased because of fixed airway obstruction. All this can be, we can get all these parameters by doing a spirometry. The cause for mechanical origin of airflow limitation are flow, as you all know, depends on the pressure by resistance. in respiratory function, flow is determined by the elastic recoil pressure and the size of the airways. But in the COPD patient, there is a decrease in the elastic recoil pressure, which results in decrease in pressure. And at the same time, because of the airway narrowing, it results in increase in resistance. Because of these two parameters, there is airflow limitation. Coming to hyperinflation, because of the damage of the alveolar tissue and obstruction, there is an increase in FRC, the functional residual capacity. When there is an increase in functional residual capacity, this leads to increase in the closing capacity also. Increase in closing capacity means that the airway starts closing at higher lung volumes. Because of this, there is air trapping and hyperinflation. To some extent, this hyperinflation is a protective reflex. Hyperinflation preserves the expiratory airflow. It increases the elastic recoil pressure. It enlarges the airway and decreases airway resistance. But at the same time, the drawbacks are hyperinflation flattens the diaphragm. When the flattening of the diaphragm results in the decreased zone of opposition between the abdominal wall and the thoracic cage, which results in the positive abdominal pressure is not applied as effectively to the chest wall, impairing ribcage movements and inspiration. And the flattening of the diaphragm also decreases the length of the fiber, producing less inspiratory pressure. At the same time, flattening of the diaphragm requires greater tension to develop transpulmonary pressure for tidal breathing. As we all know, the breathing takes place because of the generation of transpulmonary pressure gradient. And this hyperinflation results in increased work of breathing, and the work is required to overcome the resistance. Coming to the pulmonary artery hypertension, these COPD patients are prone for pulmonary hypertension. This is because hyperinflation and emphysema itself cause pulmonary hypertension, and further ventilation perfusion mismatch resulting in hypoxemia, they result in pulmonary hypertension. And further, because of the obstruction and outflow obstruction, there is hypercapnic acidosis, which results in hypertension. And further, there is because of hypercapnic acidosis, there is salt retention of salts, which results in hypertension. So these are, and at the same time, reduction in the pulmonary vasculature bed also results in pulmonary. These are the reasons for development of pulmonary hypertension in a COPD patient. Coming to the changes in the respiratory drive, in a COPD patient, because of the damage to the alveolar tissue, in COPD patient, there's a changes in the respiratory drive also. Reduced surface area for air diffusion results in chronic hypercapnia and hypoxia. This hypercapnia and hypoxia and this chronic carbon dioxide retention reduces the sensitivity of brainstem chemoreceptors. And because of chronic hypoxia, the respiration is hypoxic driven. Because of excess accumulation of carbon dioxide, finally the respiration becomes hypoxic driven, and there is also hypoxic pulmonary vasoconstriction. Now, based on these parametric findings, COPD patients are classified as mild COPD, moderate COPD, severe COPD, and very severe COPD. In mild cases, the FEV1 and by FEC ratio is less than 70% of predicted, and FEV1 is usually like normal, more than 80% of predicted value. In moderate COPD, the FEV1 by FEC is less than 50 to 70% of prediction, and FEV1 is less than 80% predicted. In severe COPD, FEV1 by FEC ratio is less than 30 to 50% of predicted values, and FEV1 is less than 50% of predicted value. In very severe cases, FEV1 by FEC ratio is less than 70, and FEV1 is less than 30% of the predicted value. So finally, coming to the anesthetic implications in a COPD patients are, the airway management becomes very difficult. There is an increased risk of laryngospasm or bronchospasm, and also in difficulty in intubation also. And there is an increased risk of hypoxemia, and patient develop respiratory failure during management of anesthesia because of decreased hypoxygenation, and carbon dioxide retention makes it difficult to maintain saturation, and supplemental oxygen may usually be required. There's increased risk of cardiovascular complications like patient going off for call pulmonary, and while giving anesthesia, pain management becomes very, very important because of the increased sensitivity to pain due to chronic inflammation and decreased oxygenation. And finally, when managing the patient in a ventilatory, in a ICU, ventilator setting and weaning has to be done very meticulously so as to maintain the oxygenation and carbon dioxide elimination. These are my references. Thank you.
Yeah. Prasad, that was a very good presentation, and you explained the pathophysiology really well,
Thank you.
So that was a good presentation, and I think we will be taking up the questions at the end of the session. So over to the next lecture. I request Raghavendra sir to introduce Namrata.
Okay. Am I audible to you?
Yes, sir.
Yeah. Okay. The next speaker is going to be Dr. Namrata Ranganath. She is qualified in MD Anesthesia. She is currently the Professor of Anesthesia at Kidwai Memorial Institute of Oncology in Bangalore. Areas of her special interest are head and neck oncological surgery and rehabilitation. She has lots of publications, 5 chapters in books and 45 publications already. So she is very active on the academic side, and she is going to now continue with the next topic. Over to you, madam.
Thank you so much, sir, for introducing me. And I thank ICA for giving me this opportunity. Now that we know what is COPD and what is the pathophysiology, I'll take you through preoperative assessment and risk stratification of COPD patients. And this is the institute I come from, and I'm working in this institute from last 26 years. This is the overview of my talk: the history, physical examination, assessment, investigation, and staging classification. So let's take the history first of the patient. In the history, we'll include smoking, progressive dyspnea, cough, sputum, breathlessness, hemoptysis, wheeze, and chest pain. By now, we know that cigarette smoking and the development of COPD has been absolutely proved. And pack years of cigarette smoking is the most highly significant predictor of FEV1. Smoking index more than 300, a heavy smoker. A pack year more than 40 is a high risk for postoperative pulmonary complication. We all know that smoking affects both our respiratory and cardiac system. It increases sputum production, decreases ciliary activity, hyperactive airway, ventilation perfusion mismatch, increased carboxyhemoglobin. It causes a smoker's polycythemia, increases risk of post-op pneumonia, and sympathomimetic effects of nicotine on heart. So the first advice what we give to a patient who comes for the surgery is to cessation of smoking. All of us know that any amount of smoking cessation in time from 12 to 24 hours to 8 to 12 weeks can have a benefit on the patient. The history of cough, whether dry, productive, or nocturnal. Sputum to see whether it is productive. If productive, estimating the volume, color, odor, consistency, posture variation with day or night, fever will help us in differential diagnosis and accordingly, if required, to treat with antibiotics. Hemoptysis, an expectoration of blood or of blood-stained sputum from the bronchi, larynx, trachea, or lungs may occur, and accordingly, we need to investigate. One of the most cardinal symptoms being breathlessness, which is defined by American Thoracic Society as a subjective experience of breathing discomfort that consists of qualitatively distinctive sensations that vary in intensity. And it is because higher the grade of dyspnea, more severe will be the disease, decreased cardiopulmonary reserve, and increased postoperative complications. So if we see the classifications of dyspnea, the Roizen's classification, which is taken when the patient walks on the same level. So grade 0 being no dyspnea while walking on the level at normal pace. Grade 1, I'm able to walk as far as I like, provided I take my time. Grade 2, specific street block limitation. I have to stop for a while after 1 or 2 blocks. Grade 3, dyspnea on mild exertion. I have to stop and rest going from the kitchen to the bathroom. And the grade 4, dyspnea at rest. And the most commonly used classification being the Modified Medical Research Council grading for dyspnea, which is none if a patient only get breathless on strenuous exercise, mild being shortness of breath when hurrying on the lever or walking up slight hill, moderate walks more slowly than the people of the same age on the level because of breathlessness or has to stop for breath when walking at its own pace on level, severe stops for breath after walking about 100 meters after few minutes on the level, and very severe is too breathless to leave the house or breathless to dress and undress. Patient can have wheeze because of mucus accumulation in the airway indicating airflow obstruction. Chest pain, chest tightness following exertion, poorly localized and muscular in character, and may arise from isometric contraction of intercostal muscle, which can originate from pleura, chest wall, and mediastinal structures. We should see the pattern of the symptom development. We should see history of exacerbation and previous hospitalization and mechanical ventilation, because a recent history of exacerbation will have much more chances of post-op complications than if it is not there. If patient has a previous hospitalization and has had mechanical ventilation, they are very hard to wean from ventilation, so they may have tracheal stenosis. A history of post-extubation stridor, or we can take later X-ray, AP and lateral view, and keeping small sized tubes may help us giving anesthesia. Current medication and their appropriateness, because most of these patients are on bronchodilators, beta-2 agonists, mucolytic agents, antimuscarinic agents. We should know what dose they are and what side effects and drug interactions are there. And especially steroids, if we take the rule of taking more than 10 milligram within 10 days and in 10 months, depending upon the dose what they take and what the kind of surgery, we need to supplement the corticosteroids. These patients are malnourished and may have weight loss and anorexia. Ankle swelling may give us a guide towards cardiac morbidity, and psychiatric morbidity may also be there. A personal history of cigarette smoking, occupational exposure, and a family history of alpha-1 antitrypsin deficiency is equally important. Coming to the physical examination, while taking history only, we could see if patient is breathless on exertion. Is there an audible wheeze? What is the respiratory rate? Does the patient look anemic, polycythemic, or cyanosed, or clubbing or nicotine stain on fingers? On inspection, we can see the central cyanosis, common chest wall abnormalities, which are seen as barrel-shaped horizontal ribs, widened intercostal space, kyphotic abdominal respiration. You can see the resting respiratory rate, see if there are accessory muscles involved, and anchor and lower leg edema. Measuring the rate of respiration, rhythm, chest expansion, AP and lateral dimension, palpation like any other chest examination of tenderness and local rise of temperature, tracheal position, cardiac impulse detection, symmetry of expansion of chest, and a tactile focal dramatis, which is decreased in these cases. On percussion and auscultation, remember, we'll get a hyperresonance. Breath sounds may be diminished or prolonged expiration. A vocal resonance is decreased, and added sounds of cracks, crackles, and wheeze may be there. Once we have taken the history and we have examined, the bedside PFTs will help us to know how is their cardiopulmonary reserve. So the most common being the subrest breath holding time, which if it is less than 15 seconds gives a poor cardiopulmonary reserve. Subrest single breath count less than 15, which shows there is a decreased vital capacity. Snyder's match blowing test, cough test, wheeze test, and maximum laryngeal height test can also be done. Coming to the investigation, a complete blood count, which may show anemia, polycythemia, raised WBC because of infection, serum electrolytes, blood sugar, sputum for culture and sensitivity, ECG, X-ray, and PFT can be done. In ECG, look for evidence of right atrial and ventricular hypertrophy, a strain pattern, or P pulmonale, tall P waves should be looked for. X-ray, you'll see an increased lucency of the lung. Bullae can be seen. There may be pneumothorax. Chest is vertically elongated with low flattened diaphragm. It's a barrel-shaped chest. A tubular heart where the heart shadow is vertical and narrow. Features of pulmonary hypertension and right heart border becomes more prominent. In bronchitis, increased interstitial markings can be seen. ABG can be used to guide ventilatory management goals. PO2 less than 60 and PCO2 more than 45 is a strong predictor of intra and post-op respiratory failure. Last but not the least, the test for cardiopulmonary reserve. The CPET being the gold standard, but VO2 max is what we are calculating. VO2 max is nothing but the amount of oxygen utilized during that exercise. If it is more than 20 ml per kg per minute, it is low mortality. We can get the same finding from 6-minute walk test, stay test, or a shuttle walk test too. Coming to spirometry, which is very, very useful in diagnosis of COPD. It's a method of assessing lung function by measuring the volume of air the patient can expel from the lungs after a maximal expiration. Preoperative spirometry may be useful to assess the disease severity and adequacy of bronchodilator therapy. So if we see the standard spirometric indices, it is FEV1, FEC, and FEV1 by FEC ratio. FEV1 being the forced expiratory volume in 1 second, the volume of air expired in first second of the breath. The forced vital capacity, the total volume of air that can be forcibly exhaled in one breath, and the ratio being the fraction of air exhaled in the first second relative to the total volume exhaled. And the vital capacities of volume of full breath exhaled in patient's own time, and it is not forced. So the primary criteria for us for this airway flow obstruction is decreased FEV1 by FEC ratio. Other measurements can be used to support the diagnosis of an obstructive defect or to assist in making decision. A restrictive defect is a proportional decrease in all lung volumes. Thus, their capacities and FEV1s all are reduced, but FEV1 by FEC remains normal. So whenever you see that there's a question whether there's a decreased vital capacities due to restriction, total lung capacity should be measured. And total lung capacity is increased in COPD either by overexpansion of alveoli or by destruction of the alveolar wall, resulting in loss of elastic tissue as an emphysema up to 10 to 12 liters. In restricted lung disease, TLC is reduced, reflecting the degree of fibrosis, and can be as low as 3 to 4 liters. So if you see here, FEV1 and FEC decrease in obstructive and normal in restrictive, and all other volumes, if you see this flow volume loop, in obstructive, the loop shifts to the left, volumes are more than normal, FEV1 decreases more than FEC, so it is low. But in restrictive, the loop shifts to the right, volumes are less than normal, and FEV1 and FEC decrease in proportion, so they are either normal or even elevated. So once we have done the spirometry, we can now classify the severity of COPD. The severity of airflow obstruction has been the mainstay for staging of COPD. American Thoracic Society has provided the criteria based on the presence of obstruction and its severity as measured by predicted FEV1. And gold guidelines include SIPNOPS also. So the American Thoracic Society classification, just now Dr. Prasad had told. And then in Gold's classification, if you see, the spirometry is done after the adequate dose of at least 1 dose of short-acting inhaled bronchodilator in order to minimize variability. So you have 4 stages, where in each stage, spirometry FEV1 by FEC post-bronchodilator is less than 0.7, but the spirometry FEV1 percentage predictive more than 80% is stage 1, 50 to 80% 2, stage 3 severe is 30 to 50%, and very severe is less than 30%. Along with this, another tool came was the COPD assessment tool, the CAT, which was totally personal subjective, where patient would talk about, I never cough, I don't have mucus, or my chest doesn't feel tight, I sleep soundly, and so on and so forth. So what they did, they came with a refined ABCD assessments tool, where they not only took the FEV1, but they took the clinical symptoms also. So you here this example, if you see, you take 2 patients, both patients with FEV1 less than 30% of predicted. But if you see, their CAT scores are of 18, and with 1 patient has no exacerbation in the past year and other with 3. So if you see here, their CAT scores are more than 18, but one had more than 2 or 3 exacerbation and another one didn't have. So however, with the new proposed scheme, the subject with 3 exacerbation in the past year will be labeled gold grade 4 and group D. And the other subject with no exacerbation would be labeled gold grade 4 group B. Another important index being the board index, a composite marker of disease taking into consideration the systemic nature of COPD, where B stands for the body mass index, O for obstruction by FEV1, D is for dyspnea scale, and XSIE for exercise capacity. Taking their scores, the approximate survival for 4 years was derived with this board index, estimating at 0 to 2.80%, 3 to 467, 5 to 6.57, and 7 to 10 points, 80%. So can we really predict the post-operative complications in COPD patient? No, there is no standard scale for that. But yes, we have seen age more than 65, smoking 40 packs per year or more, FEV1 less than 1 liter, FVC less than 1.5 liter, PO2 less than 75, PCO2 more than 45 millimeter mercury, and all the other possible symptoms with their cough, dyspnea, chest pain, hemodynamic instability, peripheral edema, heart failure, reduced alertness. Not only these, but the type of surgery, the upper abdominal surgeries, thoracic, long duration, general anesthesia, emergency surgery, reoperation during same admission have more post-op complications. So what is in our hands? Our hands is to optimize these patients so we can tell them to stop smoking, dilate the airways, loosen the secretion, remove the secretions, psychological counseling, and I would add to it, take care of their nutrition as well. So now I would hand over to Dr. Murthy to give general anesthesia after we have assessed the patients and we have stratified them. Thank you.
Thank you very much, madam. It was a very detailed assessment of the patient and the severity of COPD, so that we can prepare ourselves for proper management of the patient as had to be described by Krishna. So now hand over to the next. Thank you.
HM Krishna, he's the professor and head at this KMC Manipal, and his area of interest is pediatric anesthesia as well as simulation in anesthesia. Even though he is a very nice speaker and he so simply explains what all subjects that we have giving to him. He's such a very good speaker and he's a well-known person in all the national conferences as well as the state conferences. And he's a regional faculty and of training center coordinator of AHA training center at Manipal, volunteer for Operation Smile and in Mission Smile India, and the National Executive Council member for the Indian Association of Pediatric Anesthesiologists. And regarding the general anesthesia in COPD patients, we can now hand over to Dr. HM Krishna to talk about it.
Thank you, madam, for the kind introduction. I have no conflicts of interest to declare. I only have to express my gratitude to Dr. Muralidhar, Dean of ICA and the Indian College of Anaesthesiologists for this kind invitation. So Dr. Namrata has nicely optimized the patient, risk stratified the patient and handed over to us, and all set to give general anesthesia to a patient who is having chronic obstructive pulmonary disease. My advice is, do not give general anesthesia if a patient is having COPD unless it is inevitable. When you know that there's a problem with the airway, why unnecessarily mess with that, fiddle with that? So obviously, the choice would be regional anesthesia, but there are situations where one would have to give general anesthesia. And what would those be? If there is an evident contraindication for regional anesthesia, be it absolute, such as patient refusal, or there is an infection at the site, or it could be relative contraindications, which we all know there are several, like hemodynamic instability and so on. So when there is a contraindication for regional anesthesia and you have to give general anesthesia, we proceed with general anesthesia in a patient with COPD. If the surgery is such that it cannot be covered by regional anesthesia alone, for example, if it's an upper abdominal surgery where the surgeon is going to manipulate the viscera quite a lot, it may not be possible to do under regional anesthesia alone. Suppose it's a neuro anesthesia which would take hours together, then probably we are compelled to give general anesthesia in these situations. It could be a thoracic surgery where the surgery is being done for the pathology of COPD itself. We have a session on that subsequently, that's the lung volume reduction surgery. And if any of these surgeries of this type, that's the thoracic procedures, we will have to give general anesthesia. If the patient is so sick, has such a severe exacerbation of COPD that he requires intubation as a part of management of COPD, and on top of that, there is an emergency surgery, well, we would have to combine the supportive intubation along with general anesthesia. But please remember, even if you are giving general anesthesia, it makes sense to combine general anesthesia with a regional anesthesia because the outcomes are proven to be far better when there is a combination of regional and general anesthesia. What are the problems that we can anticipate when we are going to give a general anesthesia? Some of these have already been listed. There could be a lot of secretions which could block the tube, which could dry up, inspissate, block a distal airway also. There could be bronchospasm, which could be a nightmare, very well described by Dr. Akkamahadevi, the severity of that and the plight of the anesthetist facing that. Laryngospasm per se is not a complication or an expected problem with COPD, but it does occur in increased frequency because the airways are hyperreactive. There could be episodes of hypoxia, which manifests as desaturation. Air trapping or dynamic hyperinflation could cause, which could result in hemodynamic instability as well. The EtCO2 refuses to come down at all because the baseline itself is elevated, and throughout the surgery, we notice that there is hypercapnia. Due to chronic obstructive pulmonary disease, the circulation is also involved. There is increased pulmonary artery pressure, which could be reflected on the right ventricle also. We have the bullae sitting there, and they could rupture and cause pneumothorax, which could be simple or tension pneumothorax. And with all these problems, they don't settle only in the intraoperative period. It could extend into the postoperative period, also giving a family of postoperative pulmonary complications. Do we have to pre-medicate? How do we pre-medicate these patients? Is there a role for antisialagogue? Previously, we thought, okay, there are a lot of secretions, let's dry them up, let's give them some glycopyrrolate or atropine. But now it's being realized increasingly that they would just dry up the secretions, they would not reduce the problems. So it doesn't really make sense in giving antisialagogue as a pre-medication to these patients. Anxiolytics, yes. Anxiety itself can precipitate bronchospasm, so we don't want that to happen. So we could give anxiolytics like alprazolam, which do not over-sedate the patient, at the same time have a very good anxiolytic component. Continue all the bronchodilators that the patient is on the morning of the surgery, be it the metered dose inhaler or the nebulizations. It has been shown that the salbutamol nebulization or the ipratropium nebulizations, they are not superior to the metered dose inhalers. The patient is well versed with taking the metered dose inhalers. They are as good as the nebulization. If the patient is on corticosteroids, it makes sense to continue corticosteroids and be prepared to give a stress dose in the intraoperative period if indicated. What's the extra preparation that I have to do in the operation theater when I'm encountering a patient of COPD for general anesthesia? Beware of the OT temperature. It could be chilled out and the surgeon might be very comfortable, but the patient wouldn't be. The temperature, the cold itself could trigger a bronchospasm. So if you can reset the temperature, please do that. If you're not permitted to do that, have enough warming devices in the operating theater to keep the patient warm. Keep all this armamentarium of bronchodilators ready. Don't search for these when there is a bronchospasm. Be it the salbutamol, metered dose inhaler, nebulizers, the deepening agents, propofol, ketamine, magnesium sulfate, adrenaline, which is diluted 1 in 10,000 and kept ready in the syringe, the corticosteroids like hydrocorticosteroid, or if you're a fan of methylprednisolone, you could choose that. Preservative-free lignocaine. So there are some drugs which have put in small fonts, terbutaline, deriphyllin, aminophylline, which are sort of out of use nowadays for the evident reason that they cause more of problems than of benefit, and we have better alternatives. But there are people who think that in refractory situations, they might still be useful. So it's not a bad idea to have them ready in the OT. There's always a debate between endotracheal intubation and use of supraglottic airway devices for the surgery. Very evident that less airway manipulation with supraglottic airway device may be beneficial in COPD patient. But a word of caution, this sentence would be true only if you are familiar with the supraglottic airway device that you are using and you know how to use and you're not a novice with the device that you're using. Are you confident that you are able to ventilate the patient, manage the ventilation if the airway pressure goes up? Because when the airway pressure goes up, whatever you are trying to deliver to the patient, it all leaks around the supraglottic airway device. So are you confident in managing such a situation? If yes, you can go ahead. Would secretions be a problem? You can't do a frequent suctioning through the supraglottic airway device as you would do through an endotracheal tube. What's the type and duration of surgery? Will it permit the surgery to be done with a supraglottic airway device? Would you leave the patient on a spontaneous ventilation after inserting supraglottic airway device? Well, really not advisable, because we know that the patient can tire out, and as such the work of breathing would be high, and we don't want to push the patient to the edge. So it's still better to control the ventilation when you are using a supraglottic airway device. How do we induce general anesthesia and maintain that? Pre-oxygenation, is it contraindicated? Should we not do that? There are concerns about atelectasis, absorption atelectasis with 100% oxygen. No, forget it. Safety is the priority. There is no contraindication to pre-oxygenation, but you could do it in a better way, in a more rational way. Give a slight head end up so that the basal areas don't go into atelectasis. Keep a CPAP of 5 centimeters of water and then go ahead with pre-oxygenation. Propofol, good smooth muscle relaxant. Ketamine causes bronchodilation. Does that mean that thiopentone, etomidate should not be used in these patients? No. In fact, any of these can be used. Yes, propofol is a better agent. Ketamine is definitely a better agent, but what matters is the depth of anesthesia that you attain with these agents. If you are attaining a good depth of anesthesia with thiopentone and a poor depth of anesthesia with propofol, thiopentone is better. But if you see it has a membrane stabilizing action, and that will reduce the chance of adverse airway events. Opioids, you could use short-acting agents like fentanyl, which is preferred. We don't have any fentanyl. There's a concern with morphine about the histamine release that could be caused by morphine. It's not that morphine is contraindicated in COPD, but you have to be careful when you give. Give it slowly, diluted, and you could probably give in smaller increments rather than giving a one big bolus dose. What about the volatile anesthetics? Isoflurane, sevoflurane, halothane, desflurane. Same with your intravenous anesthetics. What matters is the depth of anesthesia rather than the agent per se. Yes, sevoflurane has an excellent bronchodilator effect. Halothane is very good bronchodilator. Desflurane has airway irritating properties, but you're not using these agents to induce anesthesia. Remember, you are using them to maintain anesthesia. As long as you maintain the MAC, maintain the depth of anesthesia, it's okay. Nitrous oxide should be used very cautiously if there are bullae, blebs. Better to avoid if you have noticed the bullae or the chest X-ray. Otherwise, if it is COPD alone, without bullae, there's nothing actually contraindicating use of nitrous oxide. Vecuronium, rocuronium, atracurium, cisatracurium, succinylcholine, any of these can be used. You need to be careful when you are using atracurium because, again, it has a propensity to release histamine, which could trigger the bronchospasm. So you would have to give that slowly if you are using atracurium. Pain should be managed very well. Pain itself can trigger bronchospasm, so make sure you give multimodal analgesia. Is there a benefit of pressure-controlled ventilation? To some extent, yes. The flow characteristics are better with pressure-controlled ventilation. The gas distributes better within the alveoli, but these days we are having a flow-controlled ventilation rather than volume-controlled ventilation, which are as good as pressure-controlled ventilation. So there's nothing like volume-controlled ventilation should not be used. What's important is you allow complete expiration. The pathophysiology of dynamic hyperinflation has already been explained. We don't want air trapping to occur. So allow complete expiration. How can that be done? Keep lower tidal volumes. 5 to 6 ml per kg body weight of tidal volume is enough. Permissive hypercapnia, accept higher EtCO2. They have been living with higher values of EtCO2, so you don't have to get bothered about that. Give a long time for expiration. Instead of 1:2 inspiratory-expiratory ratio, keep it 1:3 or 1:4. To do this, you will have to come down on the respiratory rate as well. Now, there is an intrinsic PEEP which is developing because of air trapping. So to overcome that, if you give some amount of extrinsic PEEP, like 5 to 6 centimeters of water, it splits open the smaller airways and facilitates exhalation. So this diagram shows the concept of dynamic hyperinflation. What's important is one on the right side of your screen, where what is seen on the ventilator of your workstation. If you notice that the expiratory graphic is not reaching the baseline, that means there's not enough time for expiration. You need to reduce the tidal volume and increase the expiratory time. Managing the bronchospasm, start with 100% oxygen, but do not cut off the volatile anesthetics. No, in fact, you might have to increase that because we need to deepen anesthesia, whether it is with volatile anesthetics. Sometimes they refuse to go in because there is a bronchospasm. So you would have to go for the intravenous anesthetics, propofol, ketamine, to get that deep anesthesia. You can use the metered dose inhaler puffs or nebulize with bronchodilator, that is salbutamol, which you can be using to get the bronchodilator. Here we are using salbutamol rather than ipratropium for its faster onset of action. And then we top up with other agents which do not act immediately. Remember, if you give hydrocortisone, it might take nearly 4 hours for its action, peak action to come. Magnesium sulfate might not act immediately, but at least they would be beneficial at the time of extubation. In worst scenarios, very severe cases, you would consider giving adrenaline, either subcutaneous or very small doses, something like 100, 200 micrograms intravenously. Terbutaline, dariphenane, aminophylline can cause severe tachycardias and can cause cardiac problems. Better avoided, better restrict them only if it is very refractory. Now, you can connect a metered dose inhaler directly to the endotracheal tube and give puffs through that. You have to give about 8 to 10 puffs because majority of that would just condense in the endotracheal tube. So many wouldn't prefer to give this way. What would probably be preferred is you put the canister in the 50 cc syringe and connect it to the L connector, press the barrel of the syringe synchronizing with the bag that you have in the hand so that majority of the drug is carried to the alveoli. Secretions, don't do very often the suctioning, especially in light plane of anesthesia, that itself can trigger bronchospasm. Have a high caution for pneumothorax. In extubation, you can't have deep anesthesia. You will have to wake up the patient eventually. Make sure that you don't stimulate the patient when you are waking up the patient. If you are good at deep extubation, you know how to do that, go ahead with that. Otherwise, you can have more problems with deep extubation rather than with awake extubation. Don't keep repeating drugs. Know the duration of action. If you give once magnesium sulfate, it's enough. You don't have to keep repeating. You will cause toxicity of these drugs if you repeat too often. Neostigmine will not cause bronchospasm if you have combined, and you will be combining it with glycopyrrolate or atropine. So it's only a theoretical concern that neostigmine could cause bronchospasm. Some might require non-invasive ventilation immediately after extubation. Be prepared for that. Take care in the post-operative period with regards to the temperature, oxygen supplementation, continued monitoring, and need of non-invasive ventilation. Avoid GA whenever possible. Use the anesthetic drugs judiciously. It doesn't matter actually which drug you are using as long as you know how you use the drug. Depth of anesthesia is the key factor. Keep the patient deep and do not stimulate in light plane of anesthesia. Be familiar with the problems and crises associated with COPD that will make you confident. Thank you very much.
Thank you, Dr. Krishna. for giving a simple and a nice explanation of how we have to give general anesthesia if possible. Thank you very much. And the questions will be discussed at the end of the sessions. Okay, thanks, sir.
Thank you very much. It's my great pleasure to introduce Dr. Narendra Babu, who is the professor at the Kempegowda Institute of Medical Sciences, Bangalore. May I request Dr. Narendra Babu to share his slides and start the talk. His areas of interest include obstetric anesthesia and analgesia, and he has many publications and awards. Dr. Narendra Babu, please.
Good evening, sir. At the outset, I would like to thank Dr. Muralidhar, sir, for providing me an opportunity in this talk. And I would also thank Dr. Krishna because my topic is regional anesthesia in COPD. Okay. And Dr. Krishna has elaborated why GA. Regional anesthesia, whenever there is COPD, people think of regional anesthesia, especially lower abdominal surgeries and orthopedic surgeries. People talk about regional anesthesia. So coming into my topic of discussion today is patients with COPD pose a lot of challenges to the anesthesiologist because they cause intraoperative and postoperative complications, okay, which can lead to the prolonged hospital stay and increased mortality. And anesthetic management revolves around preoperative optimization and the use of regional techniques whenever it is possible. And the primary goal of anesthesia in these patients is maintenance of oxygenation and ventilation and minimization of manipulation to the airway, which will reduce the complications. And the choice of anesthesia, as Krishna was earlier telling, it depends on the clinical state and surgical factors, type and duration of surgery. So regional anesthesia includes central neuroaxial block, which eliminates need for airway manipulation, and it reduces the PPC by about 50%. These factors make regional anesthesia a very popular choice wherever feasible in these patients. The physiological changes, whichever occurs due to the disease itself, should be thought about when a regional anesthesia is to be given. But at the same time, there are some physiological changes with the regional anesthesia, which must be understood and viewed within the context of an individual patient's pathophysiology, so that the technique used provides maximum patient benefit and reduces the risks of complications. So coming into the techniques, I need not go into the details. These are the very basics. They include spinal, epidural. Epidural includes lumbar, thoracic, cervical, and also continuous epidural. Then combined spinal epidural, then there is something called as continuous spinal epidurals. Now, I also would like to introduce some peripheral nerve blocks, especially the brachial plexus blocks in terms of upper limb surgeries in COPDs and their concerns regarding that. And there are now some new novel facial plane blocks, which I will be trying to tell you at a later date. Now, before going into epidural and spinal anesthesia, I would like to go into a little bit of physiology, which I would like to emphasize, not on patients who are with a coexisting disease. This normally happens when epidural or spinal is given with patients who are ASA1, whereas in lumbar epidural anesthesia, there are no changes with vital capacity, total lung capacity, or the functional residual capacity. Only the effort-dependent lung volumes are FEV1, FEC, and PEF are decreased in case of lumbar epidural. And in thoracic epidural, even the vital capacity, total capacity decreases to a minimal. The vital tidal volume and respiratory rate and minute volume remains the same. FEV1 and FEC and PEF, the effort dependent, once again decreases in thoracic epidural. So coming into the spinal and epidural per se, most of the effects are due to the pulmonary effects of neuraxial anesthesia are due to the motor blockade of the intercostal and abdominal musculature. And the amount of local anesthetic uptake is also a very vital, which can lead to some amount of direct myoneural respiratory depression which is seen in cases, more in cases with COPD patients. And there is something called as the pulmonary restrictive syndrome, following normally in a thoracic and abdominal surgery, which is characterized by reduction in FRC to amount of 30%, tidal volume as high as 40 to 60%, which can last post-operatively up to 14 days. And even it can increase the airway pressure, occlusion pressure is also increased, which causes a thoracic breathing pattern. Lumbar region to the mid-thoracic region leads to only minimal reduction in VC and FEV1, including the change in position from sitting to supine, which leads to a VC and FEV1 of up to 33%. So coming into the lumbar epidural with COPD patients, respiratory function is not affected either by giving a epidural or also spinal, except in patients who are morbidly obese, where neuroaxial blockade can block the abdominal wall muscles. And coming areas of concern in COPD patients are thoracic epidural. As Krishna sir was already telling, thoracic epidural, you have to be one of the contraindications. It is not an absolute contraindication. COPD patients have shown that an epidural block with bupivacaine 0.5% with the sensory block leading up to C4 to C8 leads to a decrease in vital capacity as well as FEV1. And a sensory blockade to the mid-cervical region also changes VC and FEV1 significantly, but it is clinically a safe bet. The ventilation perfusion remains unaltered under the influence of the thoracic epidural anesthesia, and this improvement, the FRC is increased because there is a decreased amount of the intrathoracic blood pressure as well intrathoracic blood volume, and the diaphragm is moved caudally so that it improves the diaphragmatic function. And more than anything, it's a better post-operative analgesia than compared to patient-controlled intravenous administration or any other IV administrations. So high thoracic epidural raises two concerns. What are these two concerns? In COPD patients, use of epidural has raised concern about the respiratory insufficiency due to the motor blockade and risks of bronchoconstriction due to sympathetic blockade. The systemic effects of the local anesthetics which we are going to administer through the epidural attenuates most of this bronchial reactivity and overrides any possible negative effects of the sympathetic blockade caused by high thoracic epidural. Coming into cervical epidural, this seems to be practical and also safe alternative to GA, but it reduces vital capacity and FEV1 to a degree similar to that in the high thoracic epidural. With the use of high concentrations like bupivacaine of 0.5%, there is an additional increased risk of 0.8% of developing high muscular blockade with cervical epidural. So coming into the effects of the local anesthetics, commonly used local anesthetics, the MI type attenuate and even block afferent and efferent and the conduction of autonomic nerve fibers. This is a dose-dependent effect. Systemic effects of amide local anesthetics contribute beneficial effects in cases of COPD because it causes improvement in lung function, in particular with patients with obstructive airway disease. What are the major factors that influence the local anesthetics? One is the concentration of the local anesthetics that we are going to use and the volume of the local anesthetics that is being used. And the minor influence is the choice of local anesthetics. Whether you use bupivacaine, you use ropivacaine or lidocaine, it does not have much influence. So coming into patients with COPD undergoing laparoscopic surgeries, with minimally invasive procedures being an order of preference today, except for cesarean section, every other thing is a minimally invasive procedure. And recently, minimally invasive surgeries means preferred type of anesthesia, was general anesthesia. Recently, however, large studies have suggested that regional anesthetic techniques like spinal anesthesia, paravertebral blocks, continuous epidural or continuous spinal, continuous epidural with combined with a non-invasive positive airway pressure is helpful in laparoscopic procedures. Why? Respiratory function is not affected either by giving spinal or epidural at lumbar level, except the FEV1 to FVC ratio may decrease to around 20 to 25%. And these patients will have a good ability to clear their bronchial secretions. The one factor in laparoscopy using regional techniques is the discomfort of the pneumoperitoneum and the associated shoulder pain, which can be overcome by using a small dose of either sedatives or either a small doses of opioids. And combined spinal epidural is a better option in high-risk patients because it provides safe and effective neuraxial blockade when compared to epidural alone. Laparoscopic surgery is not only feasible under RA, but should be considered, I feel, as a valid option for the patients who are poor candidates for general anesthesia with advanced COPD. There are certain limitations. There are positive of the data. There is data doesn't provide us much backup for usage of regional anesthesia and laparoscopic procedures. And there is also some amount of concern about safety and efficacy of regional techniques, which has to be evaluated independently with regard to the relative risk and better cost-effective ratio. And the use of non-invasive ventilation. Spinal and epidural are used in severe COPD patients and patients who are not able to recline or lie down. So these patients who are not able to recline or lie down, some amount of sedation can be used and reassurance can be given. And when you want to avoid a general anesthetic in these sort of patients, the use of NIV comes into play. The maintenance of spontaneous breathing means there is less cephaloid displacement of the diaphragm, which reduces the diaphragmatic pressure, which also, and at the same time, it decreases the risk of atelectasis at the same time. Closing capacity and FRC are less affected and pulmonary gas exchange is better maintained. Sedation given in conjugation with regional block decreases sensitivity to carbon dioxide and hypoxia, and thus these patients may sometimes have to deal with hypercarbia and hypoxia. And also the combined effect of pneumoperitoneum in laparoscopies and sedation can lead on to hypoventilation and oxygen desaturation, which cannot be treated with conventional methods like nasal prongs and oxygen mask, and then the use of NIV comes into play. The use of non-invasive positive pressure ventilation helps to ameliorate the effects of also lie flat and helps in improving the oxygenation. So what is the type of non-invasive ventilation that is being used? Non-invasive ventilation is used using bi-level positive airway pressure, which helps to maintain oxygenation. And the higher inspiratory pressures kept in IPAP, inspiratory positive airway pressure, aids in ventilation, whereas the lower expiratory positive airway pressure increases extrinsic PEEP, thus counterbalancing any intrinsic PEEP that is inherent with COPD patients. And thus this recruits underventilated lungs as well as increases the tidal volume, reduces the respiratory frequency and decreases the work of breathing. So NIV in combination with regional anesthesia is very helpful in patients with severe COPD patients. And coming into the peripheral nerve blocks, the most commonly talked about peripheral nerve block is the brachial plexus blocks. Alteration in mechanics with brachial plexus blocks are primarily due to phrenic nerve blockade or hemidiaphragmatic paralysis. And there are certain controversies with interscalene block. What are these controversies? Interscalene block per se causes blockade of phrenic nerve as well as hemidiaphragmatic paralysis 100%, whereas supraclavicular approach has 50 to 60%. So how do we make use of this brachial plexus block in patients with COPDs? So risk of peripheral nerve, phrenic nerve blockade decreases as you move along distally away from the plexus. This can be achieved using two other blocks. One is the axillary approach or the infraclavicular approach. Infraclavicular approach through the coracoid process is ideal in patients with COPD. And infraclavicular will not cover the complete upper shoulder. So infraclavicular, when combined with supraclavicular block, is an ideal anesthetic technique in patients with COPD. And next, coming into axillary, axillary will also not cover the full shoulder. So axillary with suprascapular will reduce the risk of whatever concerns involved with interscalene block. So there are certain clinical pearls which I would like to quote. These are from the NYSORA guidelines. Interscalene block with the advent of, ultrasound, you can give as low as 5 ml. Even 5 ml of interscalene block will not reduce the risk of phrenic nerve block. Therefore, interscalene block is better avoided when there is a severe COPD. The other pearls from NYSORA include phrenic nerve block is not of much importance in cases of asymptomatic or mild COPD patients. The use of continual brachial plexus block should be carefully considered in patients with pre-existing significant pulmonary disease. When indicated, a catheter should be placed, but small doses of local are to be given. In symptomatic patients with indwelling catheter, a washout technique can be used, which is helpful. So regional anesthesia and cardiac surgeries. Thoracic was plain regional anesthesia alone. We don't have a lot of data, but it has been tried in cardiac surgeries. But regional anesthesia is always with epidural anesthesia. Regional anesthesia goes along with, in combination with GA, as provided superior postoperative anesthesia, which benefits early extubation, and the cardiac sympatholysis with regard to myocardial ischemia has been used. Thoracic epidural for cardiac surgery, in contrast to non-cardiac surgery, the 30-day mortality has no improvement. There is still a debate whether to use regional techniques in case of cardiac surgeries because of the use of the anticoagulation, which has been a fear for epidural hematoma and possible paraplegia. So the risk benefit should be verified, but the data, positive data is holding us use of regional alone in cardiac surgeries, but cardiac surgeries can be used with GA with epidural, as Dr. Krishna was saying, a good combination. And there are certain novel facial blocks. These novel facial blocks helps to control the patients postoperatively. These are one of the regional techniques, 2011. Afterwards, it has been used with wide implementation of minimally invasive surgical approaches. The novel techniques and the ultrasound guided has helped. These we have moved away from the usage of neuraxial anesthesia, where we are worried about the anticoagulation and hemodynamic instability. The new novel facial blocks will reduce with reduced complications, are used in thoracotomy or sternotomy, and the future lies in usage of this new novel blocks, especially the ESP, which is erectospinae block, which can be used from lower down up till the cervical region. These are some of the new novel facial chest plane blocks which can be used in COPD patients and in cases of cardiac patients. And what are the concerns when you are using a regional block? Corticosteroids are not normally given orally, but when recommended only in severe cases, these patients can have osteoporosis, immunosuppression, and acute adrenal insufficiency can be seen at the time of stress and surgery. Patients dependent on steroids should be replaced preoperatively, as Dr. Namrata has already told. And these patients have a poor nutritional status. So nutrition is important. And in regional anesthesia, nutrition is very vital because the dose and concentration of the local anesthetics should be taken care of, as pre-available drugs will be more, and at the same time, duration of these drugs will be prolonged. So you have to be careful. These are few concerns with COPD patients because of the extrapulmonary actions of the COPD. And coming into the conclusion, the use of regional anesthesia in patients with COPD is associated with lower incidences of composite morbidity, pneumonia, prolonged dependence, and it avoids unplanned post-operative intubation. And recent evidences favors the use of regional techniques for anesthesia and analgesic management in these patients wherever feasible. And the last important point I would make to emphasize is COPDs have neuropathies. We have to bear in mind, and whenever regional anesthesia techniques are used, kindly look into the neuropathy like you look into the diabetic neuropathies. With this, I conclude and I thank and I wish all my moderators and my colleagues a happy new year. Thank you.
Thank you, Dr. Narendra Babu, for that excellent presentation on regional anesthesia and COPD. Now I request Dr. Akkamahadevi to continue the session.
Sir is working as professor and currently senior professor, Department of Anaesthesiology, Pain and Critical Care at Akash Medical College, Bangalore. Sir's areas of interest are regional anesthesia and intensive care, and has many publications and has worked as former vice president and president of Bangalore City chapter. Over to you, sir. Kodandaram, sir.
Am I audible?
Yes, sir.
Okay. The screen is seen?
Yes, sir.
Okay. Thank you for the introduction. Greetings from Akash Medical College to all of you and for the new year. And now my topic is on ICU management of acute exacerbations of asthma and COPD. Both I am going to cover because they are similar. Both COPD and asthma are characterized by expiratory airflow limitation. This is reversible in asthma but not fully reversible in COPD. The exacerbation of asthma or COPD causes further increase in airflow limitation due to inflammatory swelling of the airways. And the cause for this, in case of asthma, most of the times it is due to external pollutants in the environment or allergens. And also it could be due to some upper respiratory infections, either bacterial or viral. Whereas in case of COPD, most of the times it is due to infection, upper respiratory infections. But whenever there is exacerbation, you must also make sure whether it could be the cause of dyspnea could be to some other cause, like acute coronary syndrome, or pulmonary embolism, foreign body in the airway, or in children, especially CROP, bronchiolitis, and then cardiogenic cause. And today's background of COVID-19, we must think of COVID-19 also, whether it is manifesting like an asthma or COPD exacerbation. Regarding the investigations, no specific lab test is there for the etiology of COPD or asthma exacerbation, but we can do the CDC, the sputum testing, ABG, capnography, ECG, chest X-ray, and spirometry. And very important is ultrasound. So it gives a lot of information. And spirometry for FEV1, FVC, and PEF will also be useful. The severity of the exacerbation is always assessed by clinically and by times. And the GINA and GOLD guidelines says spirometry like a PV1, FVC, and PEFR, but in the setting of exacerbation, it is really not possible to do the spirometry. These patients are struggling for a breath. But ultrasound is very useful for lung imaging, and also it helps to other causes of acute dyspnea like pneumonia, pleural effusion, consolidation, or cardiogenic edema. Further, at the time of weaning, it helps to know the degree of respiratory muscle function by knowing the thickness of diaphragm and parasternal inspiratory muscles at the time of weaning. The fluid stress is very important because most of these patients are fluid deprived and they may be having dehydration, and it can be assessed by USG. So we will divide the management into initial management, where we will deal with oxygen, bronchodilators, corticosteroids, antibiotics, and critical management, respiratory support, and pharmacological management. And lastly, subsequent management, where a lifestyle modification important for preventive purposes. Now, in the initial management, oxygen therapy is very important. It must be titrated 88 to 92% in COPD patients, 93 to 95% in asthma patients, because high levels of oxygen will actually affect the patient because it will abolish the hypoxic drive and then unload the carbon dioxide, or it will abolish the HPVC reflex. All this will produce high PCO2. Bronchodilators, there are short-acting beta agonists, blocking beta agonists, and anti-allergies like ipratropium. But if they are combined, it's a better result. When they are not combined, also they may be useful in milder type of exacerbations. The longer acting agonists are useful in preventive purpose, so short-acting beta agonists are better, and they can be given by nebulization or MDI spacer. In the MDI spacer, if it is used, more drug is set to reach the lungs when compared to the nebulizer. So MDI spacers are better. Also, in the background of COVID, it is better if it is used MDI with spacer rather than nebulizer. But nebulizer in exacerbation is much more comfortable for the patient when compared to MDI and spacers. These are common side effects of the short-acting beta agonists. And one word about epinephrine, it was told by other speakers also. It is the most underappreciated and underused drug in asthma. And that is because fear, hypertension, tachycardia, and myocardial ischemia. But it is time to revisit adrenaline as one of the top first-line treatments in selected cases. Regarding the corticosteroids, are very powerful anti-inflammatory drugs, but they are slow to act, take 4 to 6 hours. So during this time, we have to do is depend on the bronchodilators, and then by the time the anti-inflammatory effect of the steroid starts, there will be considerable relief from the exacerbation. There is a lot of debate regarding the route, dose, duration, and type of the corticosteroids, and it is not much difference between the oral or parenteral corticosteroids. The duration of treatment is about 1 week to 2 days. No tapering is recommended if it is given for this duration. High doses are unwarranted, and side effects will occur if more than 2 mg per kg per day of prednisolone or methylprednisolone is given. So we find that the inhaled bronchodilators in the case of COPD, they are not required that frequently or high dose, and no IV preparations are also required. But for asthmatic patients, the beta agonists or ipratropium, more number of puffs are required and larger dose is required. They literally have to be fumed with these bronchodilators back to back, and sometimes even continuous nebulization may be required. And if it is not successful, your infusion of salbutamol is required. And in occasional cases, epinephrine may have to be given. 0.5 milligram is also recommended, sometimes 2 times, about 15-20 minutes interval. So this is the type of a very bad asthmatic attack. The antibiotics are required in bacterial because there is an element of bacterial infection in COPD patients, but there is no need in the case of asthma patients. Now, with this, if there is not much improvement, then the next choice is the critical management of these patients. So what is to be done is to put the patient on NIV, non-invasive. It is a standard of care mainstay of therapy in acute exacerbation. It provides external PEEP which counters intrinsic PEEP and hence helps in better oxygenation. The settings are IPAP 15 centimeters of water, EPAP 4 to 5 centimeters, and FiO2 88 to 92. This is for COPD. In asthma, there is paucity of data regarding use of NIV. Anyway, we can give a short trial, but there must be a low threshold to intubation, and EPAP alone is sufficient, 7 to 10 centimeters. FiO2 should be titrated to a level of 93 to 95%. These are the common contraindications which are well known to NIV. What about HFNO? There is theoretically a lot of advantage for HFNO, but there is no still evidence. It has to still build for whether useful in asthma and COPD. But theoretically, the high flow will produce good CPAP and will wash out carbon dioxide, will also help in humidification, and patient will be comfortable, communicative, able to take food orally. The key to success in the management of exacerbations is continued optimal persistent pharmacological support plus ventilation strategy. So if the patient has failed NIV, then the next thing is mechanical ventilation, especially if the patient is going to refractory hypoxia or fatigue or worsening respiratory failure, cardiorespiratory arrest. The patient has to be intubated with rapid sequence induction using drugs like ketamine, propofol, shocuronium or suxamethonium. One word of caution is at the time of intubation, there may be possibility of bronchospasm or tension pneumothorax. Post-induction agent hypotension is possible, which can be prevented if a fluid bolus is given just before intubation. Intraoperatively, there must be a high level of suspicion to know whether there is any onset of pneumothorax. Now I will go to one very important concept, the concept of dynamic hyperinflation. So in the normal lung, there is balance between the pressure inside the airway and just outside the airway. So this interplay will balance out and at a point called equal pressure point, which is near the cartilaginous portion of the bronchioles. Therefore, the flow is not affected much, expiratory flow is not much affected. But in the case of either COPD or asthma, there is disease in the airway. So either in the form of spasm or mucus or loss of elastic traction, radial traction, elastic recoils. So on account of all this disease, the external pressure is more compared to the internal pressure, and therefore there is a collapse at that point due to dynamic obstruction. This obstruction is compression is going to cause decreased expiratory flow rate beyond this point where there is the equal pressure point. This is called equal pressure point where they are equal. So beyond this, there will be limitation. On account of that, some amount of air gets retained, and this retention is going to cause auto peak. This is what is called air trapping. And successively, with every breath, the amount that is trapped will increase during expiration, and the lung will become bigger and bigger than for expiration. And this can take place in forced expiration. This is what I have been telling. But in the course of the disease, as the disease progresses in COPD, you find, and also even in asthma, even in normal breathing, the equal pressure point may go towards the alveolus, and therefore, even at lower, the beginning of expiration itself, there may be the trapping of the air. So this graph was shown by Dr. Krishna. So the expiratory flow in this loop is not touching the base. That shows that there is trapping and there is a buildup of the end expiratory volume with successive breaths. Now the second concept is the concept of peak inspiratory pressure. The inspiratory pressure the peak inspiratory pressure is because of the interplay of not only the airflow but also the elastic recoil of the lung, and so it produces a peak inspiratory pressure. Supposing we give an inspiratory hold, then there is no flow. So whatever pressure we record is due to the elastic recoil of the lung plus the intrinsic PEEP, whatever air is there at the end of inspiration. So this plate of pressure can be therefore taken as a surrogate of the intrinsic PEEP of the patient. Similarly, if at the end of expiration, if the expiratory flow is stopped by giving expiratory hold, then what happens is some pressure, whatever it records at that time, is equal to the pressure that is exerted by the air remaining in the alveoli at the end of expiration. Nothing but the intrinsic PEEP. So the intrinsic PEEP can be therefore measured either by expiratory hold or by inspiratory hold. So in this particular graph, you see that there is an intrinsic PEEP in this particular graph. Now, supposing the respiratory rate is reduced, then it has disappeared. Similarly, if the IE ratio is increased, then the intrinsic PEEP has disappeared. So that means this is in patients with dynamic hyperinflation, which is the other name for auto PEEP. Either we have to reduce the respiratory rate or reduce the volume of ventilation or increase the IE ratio. That's how we can manage these patients to avoid the intrinsic PEEP. So the strategy in the dynamic hyperinflation, that is auto PEEP, is we give a volume cycle ventilation. Volume inspired is only 6 ml per kg, rate of 14 per minute, and high inspiratory flow rate of more than 70 to 90 liters per minute. IE ratio 1:4 or 1:5 also. And increased expiratory time. The plate of pressure, which I mentioned, should be targeted to less than 25 to 30 centimeters. The same way, the intrinsic PEEP should be less than 12 centimeters. As far as the ventilatory mode is concerned, whatever the intensivist is used to, whether volume control or pressure control can be employed, but most of the intensivists use volume control ventilation only. There is also they fear that with pressure control ventilation, there may be little increase in PaCO2, because here the pressure is controlled, the volume will be less. If the volumes are delivered may be less, resulting in increased PaCO2. But for that reason, we should not increase the respiratory rate, or we should not raise the tidal volume. We should accept what is called permissive hypercapnia. This is the third concept you have to understand in the management of the asthma in the ICU. So permissive hypercapnia means you accept till the pH of 7.15, as long as the PEEP plate of pressure is less than 25 to 30 centimeters. And the patient can be put on SIMV, PSV, AC mode, PSV, or in very bad cases, even controlled ventilation with complete neuromuscular paralysis and sedation. The important point is that during the management of the patient in the ICU, there is nothing like a fixed particular settings. We have to keep on checking the waveforms, and we have to follow it up and keep changing as when it is required. Regarding the application of external PEEP, it is controversial. No PEEP is advised if the patient is deeply sedated, paralyzed, and is not breathing spontaneously. On the other hand, if the patient is breathing spontaneously, as in SIMV, or trying to trigger, then we have to give PEEP, and this PEEP is about 80% of the intrinsic PEEP. And E-PEEP is not recommended in asthma patients. So this is only in COPD patients. In asthma patients, E-PEEP is not recommended by majority of the papers. So why are we so much bothered about this auto PEEP or dynamic hyperinflation? It produces rise in intrathoracic pressure, produces a tamponade type of effect on the heart and on the lung, and produces hypoxia. So two important complications I will deal with. So one is the pneumothorax, which can happen either spontaneously or during IPPV or during interventions like CVP line introduction. So if we don't diagnose it in time, it can become even contralateral lung overventilation will take place, and it can become bilateral pneumothorax. Therefore, there must be a high degree of suspicion for pneumothorax in all these patients that are put on IPPV. And the first thing we have to do is to decrease the ventilator rate and go for intercostal catheter, which has to be introduced under blunt dissection. The second important problem is the severe hypotension and even cardiac arrest due to auto PEEP. So if there is such a scenario, what you should do is just disconnect the ventilator for 1 minute and do manual deflation of the chest. The chest will be silent. It's called silent chest. And then after a minute, we can connect the patient back to ventilator and resume ventilation at a lower rate and lower tidal volume. It is going to be successful in many of the cases, and it happens in status asthmaticus or in other case of silent chest. In continued hypertension, which is very refractory, there are anecdotal reports of use of either IV adrenaline or, as our other speakers told, IV magnesium sulfate, etc. There is also there are also reports of using helium-oxygen mixtures, anesthetic gases, and ultimate even extracorporeal membrane oxygenation to remove carbon dioxide. These are all reported in the literature in very refractory cases. The third problem which we come across in the ICU is ventilator dyssynchrony in exacerbations of asthma or COPD. It is due to ineffective triggering, wasted efforts. And what you have to do is you increase the sensitivity of the inspiratory trigger, decrease the pressure support, decrease the tidal volume. That is going to help in dyssynchrony. And there are novel methods like the neurally adjusted ventilation, NAVA, proportion assisted ventilation like PAV. And these are newer things, and they are not evidence proved as at present. So when the patient's precipitating factors are all taken care of and exacerbation is resolved and DHI, it cannot be totally taken off, but it is manageable, then you will go for weaning. So when you wean the patient, put the patient on spontaneous breathing trial, and if all the parameters of oxygenation and ventilation are fine, decrease the respiratory support progressively. During this time, I want to make a point. The patients are on glucocorticoids or neuromuscular blockade might have been given, sedation might have been given. So that will come in, that may cause myopathy, and the patient might not be able to wean very easily. Very important point I have to make here, when the extubation is done, it is a trial of extubation. So after the extubation, we are not sure whether the patient can hold. So post-extubation, it is always wise to put the patient on either NIV or high flow nasal oxygen, and that will help in reducing the incidence of re-intubation after the patient is extubated. This requirement of NIV is generally not there in asthma, but it will be most of the times needed in COPD. To help in the weaning process, the ultrasound is very helpful because, as I told before, 30% rise, if it is there in the thickening of the diaphragm during inspiration or parasternal muscles, then it indicates that it is probably going to be a very successful weaning. Tracheostomy may be required, especially if a lot of morbid situations are there with COPD, with other problems in them. Whereas asthmatic patients, only bronchospasm, usually other morbidities will not be there. So tracheostomy is not that commonly required in asthmatic patients. A very small minority of COPD patients may become unweanable. Many COPD patients need even home ventilation and may require readmission after discharge. Post-ICU care for prevention for both asthma and COPD patients, long-acting bronchodilators and steroids are advised, and patients should be advised self-care, like with PA for checkups and additional inhaled bronchodilators. They must be advised to submit to medical care early. When they are well better, then the flu or pneumococcal vaccines should be advised. And lifestyle modification, tell the patient not to get exposed to bad environment, patient education, these things are important in the post-ICU care. So in summary then, regarding the therapy for these exacerbations, controlled oxygen and air are important in COPD cases. Helium and oxygen is good for asthmatics. Beta agonists, anticholinergics, magnesium and steroids are all required in very high dose and very frequently in the asthmatic patients compared to COPD patients. And theophylline and other methyl xanthines are useful in IV, and especially IV is useful in COPD patients, but not in asthmatic patients. Ketamine and volatile anesthetics are useful in asthmatic situations. And NIV and EP, both of them are not that much recommended for asthma, unlike the COPD patients. ECMO also is said to be useful for asthma. And pre-morbidity, both morbidity and prognosis, this is quite good in asthmatic patients, but very poor in the case of COPD patients. So in the summary is, NIV or high flow nasal oxygen salvages majority of exacerbations in COPD and asthma. Bronchodilators and corticosteroids are the first line of therapies in exacerbations of both types. The major goal is to limit the auto PEEP and not to normalize the ABG. You have to accept some amount of hypercapnia, permissive hypercapnia is the important concept there. And mechanical ventilation is the cornerstone of therapy for respiratory failure only when NIV fails. And regarding the PEEP, low levels of PEEP only to be used only for patients triggering ventilators. Post-extubation, NIV or HFNO prevents re-intubation. Additional strategies like NAVA, PAV, and extracorporeal oxygenation are not fully evidence-based. Thank you. Thank you very much.
Okay, sir. So this auto PEEP question is there in the chat that was already answered by Kodandaram sir. I don't think we have to go into that. And yet another question was regarding pethidine, sir, having vagolytic action, whether it can be used in these conditions. Can Krishna take this?
Yes, madam.
Yeah.
Pethidine can be used in hyperreactive airway disease like COPD, or as the question has been asked, asthma. But just because it has some vagolytic action, it doesn't mean that you could use that vagolytic action in benefit of COPD causing bronchodilation. No. Okay, that's not going to help COPD. It's not contraindicated in COPD. You could use it, but use it as cautiously as you would use in any other case. Be mindful about the accumulation of norpethidine with repeated doses of pethidine, or if you are contemplating infusion, better not use it as an infusion, because norpethidine accumulation can cause problem whether it's in a COPD patient or a not COPD patient. To summarize, the vagolytic action of pethidine per se will not give any added benefit. There are better vagolytic antimuscarinic agents for management of COPD.
Yes, and in fact, pethidine has been removed from the armamentarium of an anesthesiologist for several reasons. So the students these days, I don't think they should really think of pethidine. That's it.
Madam,
so,
shall I say? Madam?
Yes, ma'am.
Because before the availability of fentanyl freely, we were using this pethidine. So once the fentanyl is available to us, now we have almost completely stopped using pethidine. That is what is happening now. I don't know how much it is using from the outside, that is in the periphery and all. I don't know. But the fentanyl, after the availability of fentanyl, we are not at all using pethidine.
Muralidhar sir, you have anything to say about
this pethidine? Frankly, I have not used it for more than 20 years now. We have short-acting agents, fentanyl, that you can titrate the dose and adjust the dose as needed. You can give it as infusion if needed, and exactly see how the patient is responding and then adjust it. Having said that, these patients may be sensitive to narcotic agents, so you have to titrate the dose and reduce the dose of agents and then see the effect, and then only give the full dose if needed be. So that's my take on this narcotics in COPD. One question I would like to ask Dr. Krishna is, when we intubate these patients for general anesthesia, what PAC would you like to keep? What is your, do you bring it down to normal levels, or you gradually bring it down to reduce it gradually, or you keep it at the patient's baseline level? What is the strategy you follow?
If we have a ABG, the preoperative ABG, then we know the baseline value of the patient, and we know that the patient is used to this baseline value. So however high that is, we know how the clinically patient is faring with that baseline value. And we make some adjustments for that with regards to EtCO2. And then we would set that as target rather than having the normal range of values, what we would take as the reference values for individuals. In fact, we shouldn't be taking that as the normal range for COPD patients.
Thank you for that response.
Pethidine, I want to add that pethidine, of course, it is not being used very commonly, but still, for academic purposes, I am telling that though it is vagolytic, it also produces, due to vagolytic effect only, it produces bronchodilation. There is one difference. The second difference is histamine release is also not there. So these are the two some points in about pethidine.
Yes, thank you for that.
So very often, one thing I would say, when it comes to genetic factors implication, the recent one is that there is FAM13A genetic variant, which is known to cause COPD in patients. That is one thing, along with like the antitrypsin deficiency. And which other, and one more question which our examiners would ask when we were students is, if the chronic bronchitis and emphysema, two situations are there, which you would prefer to have? That used to be the most popular question. So we were supposed to say it is chronic bronchitis because of the hypercarbia and such things. And oxygen saturation is low and those things. And one more for Krishna, I was just wanted to know the respiratory rate being kept low and the inspiratory-expiratory ratio being high. Is that of disadvantage to some extent with respect to oxygenation and accumulation of carbon dioxide? That's one more thing that I wanted to ask you.
Yes, madam. The major disadvantage would be with respect to carbon dioxide.
Yeah.
Because we are actually coming down on the minute ventilation of this patient. We are telling low tidal volume. We are restricting on the tidal volume. We are cutting down on the respiratory rate also. Only thing is we are giving enough time for expiration. So as a result of all this, we are going to have hypercapnia, and this should be permitted and it should be acceptable. But how much would be acceptable is something which has to be individualized to the patient. Suppose the hypercapnia itself is causing increased surgical bleeding and tachycardia and other unwanted effects, then probably we will have to titrate the respiratory rate and tidal volume so that we bring down. So that titration would have to be individualized.
Yeah, and it's also said that the inspiratory flow has to be increased.
Yes,
that's one more thing that has to be taken care of. And I think extubation also should be given as much as important that we give for intubation, with provision for non-invasive ventilation after extubation, isn't it? That was one more thing that I just wanted to add on to the thing. And yet another question, if nobody has any question to ask, yet another thing that our examiners used to ask is the differential diagnosis for our tight back. When we used to have manual ventilation, so now, of course, you look into your monitor and see increased peak airway pressure and decreased tidal volume and all those things. So for the benefit of the postgraduates, one more very favorite question of examiners would be the tight bag and the differentials, whether it is extrapulmonary and intrapulmonary and such things. And I also feel the duration of surgery, the surgeon is also very important, especially when you go in for regional anesthesia. That's what I feel. That's my feeling. And Narendra Babu,
yes, ma'am.
You very well spoke about the interscale block, when it has to be avoided and all that. So our boys these days are taking up a study only the upper trunk, you know, the way from where the suprascapular nerve exits.
Yes.
Okay, so very low volume under ultrasound guidance, if you can give just 2 ml or 3 ml, it will be equivalent to giving a suprascapular nerve block. But of course, you can either, even go ahead with the blocks lower down and suprascapular block. That can also be done. And this point also can be taken a very low volume at the...
Even with the low volume, ma'am, as low as 3 ml, they've had fleeing nerve paralysis. So the best message is for the student is whenever severe COPD of less than 30%, try to avoid interscalene blocks. Go ahead with infraclavicular block combined with suprascapular.
Yeah, that's all.
That would be ideal. What the problem with infraclavicular is the technical perfection. That needs little amount of
very true.
perfection.
And that, sir, anything else? Any of the other moderators?
There is one question about
Shall I ask, madam?
Can you just go through
one question to Dr. Narendra Babu?
Yeah, Shamshad.
Madam, is there any role for the... Sir is saying something.
Yes, sir.
Murali, sir. Shall I continue, sir?
After you.
Okay. Nowadays, it is said that segmental spinal anesthesia can be given for upper abdominal surgeries like cholecystectomies, gastrectomies, like that. Sir, anything like that, Dr. Narendra Babu?
Yes, segmental spinal and continuous spinal are order of the day, but the literature and paucity, there's very little data regarding this. But they are mentioned in literature that continuous spinal as well as segmental spinal can be given for upper abdominal surgeries. The main reason here is the movement of the diaphragm downwards and spontaneously breathing patients. This will help such
But
patients.
also we have to assess the patient as well as the distance between the spinal as well as the extradural before we plan for this segmental spinal. And also we can give the isobaric solutions.
Isobaric solution.
And that also only very minimal dose with the by adding fentanyl about 15 to 20 micrograms can also be given. I haven't tried it, but in a discussion like this, I want to highlight the point. That's all.
It's there in the literature, I am not told. What
Yeah, okay,
the beginning I am told is the minor influence in such thoracic or epidural or spinal is the choice of the local anesthetic, which is minor, but the concentration of the local anesthetic is the most important thing in choosing.
Okay.
And I think the question by, sorry sir, question
yes,
by in the chat box is being answered now, I think. The question was, does high spinal depress expiratory drive and cause raise in CO2?
Yes, ma'am. This high spinal causing raise in CO2 is not by the muscles or the motor blockade. It is because when there is an high spinal, it is mainly due to the central effect, that is the brainstem hypoperfusion, which will cause apnea and the expiratory drive is lost. You can manage it with ventilation and treatment of fluids.
Muralidhar,
Thank you so much. I think we are exceeding the time limit, so we need to wind up the show. And I would like to thank all the participants. Everybody has done extremely well beyond my expectation. Dr. Akkamahadevi, Dr. Raghavendra, Shamshad, Beegum for participating as panelists. Thank you very much. And Dr. Prasad spoke about definitions and pathophysiology. Thank you once again. Very well done. Preoperative assessment done by Dr. Namrata. Very nicely covered all the points. Krishna said about management of general anesthesia. Thank you very much. Regional techniques in COPD, Narendra Babu did a good job. And ICU management, Dr. Kodandaram, thank you so much. You took us through the intensive care management of acute exacerbations. And I'm really indeed grateful. And I request Dr. Jayashree Sood to take over for the vote of thanks. The dinner is getting ready, the virtual dinner is ready. So before that, we'll have the vote of thanks. Thank you so much.
Thank you so much.
Meet you,
hi. Thank you, Dr. Kanchi. And good evening, everybody. It's a great pleasure and honor for me to be proposing this vote of thanks. And at the outset, I would like to say that I'm so happy to see Dr. Akkamahadevi after such a long time, and also Dr. Shamshad Beegum and Namrata. It's really nice. And thank you so much for making this webinar so lively, along with all the speakers, as Dr. Muralidhar has also already enumerated their names, Dr. Prasad, Namrata, Krishna, Narendra, Babu, and Kodandaram. Thank you so much. All the topics were so relevant and indeed very, very beneficial for the students, as Dr. Akkamahadevi repeatedly pointed out the important points for the students, which are still asked to the students during their exams. And excellent. I really didn't know how the 2 hours passed by. Thanks a lot. And this was, as was told earlier, the 128th webinar. And we're very happy that every time the standard is going higher and higher. So thanks a lot. And good night, everybody. And see you all next week.
Thank you, ma'am.
Wednesday. Thanks a lot.
Thank you. Thank you very much.
Thank you. Thank you so much. Thank you. Good night.